The difficulty that we have is that largely patients with, for example, progressive supranuclear palsy, that's a rare disease. It looks a bit like Parkinson's disease initially. The same goes for corticobasal degeneration. For both of those diseases, if you were going to give them a drug to treat the abnormal tau in their brain, you would have to diagnose them as a tauopathy and not, as is often the case, as an alpha-synucleinopathy, where people think, well, I think you have Parkinson's disease for a few years, and then when there are obvious changes from the way that you'd expect someone with Parkinson's disease to develop, you then say, oh no, actually this isn't Parkinson's disease, an alpha-synucleinopathy, this is PSP, a tauopathy, and therefore you can have this treatment. The other thing is that for corticobasal degeneration, or corticobasal syndrome, which is what we see from the outside, the phenotype of the presentation, we know that various pathologies can cause that phenotype or that presentation. So, for example, you can have Alzheimer's disease pathology causing a corticobasal syndrome phenotype. You can have motor neuron disease pathology causing a corticobasal syndrome phenotype. PSP, and for example, in Alzheimer's disease, which is much more common, you can have a mixture of pathologies causing the Alzheimer's disease phenotype, such as vascular causes or vascular problems in the brain causing memory problems. PSP is fairly unusual in that if you have clear physical signs, such as postural instability early in the course of the disease and eye movement disorder, predominantly of saccades, then actually you can be right about the pathology causing that problem 95% of the time. So although we don't have a biomarker, as we might do for other diseases like Alzheimer's disease, we can be relatively specific about the pathology that's causing the problems in PSP. So that's very useful.